This is the lecture for Unit 4. It's called Body and Self and Suffering and Healing, Pain and Experience. So in this unit, we're going to follow up and build on something that we've already talked about in Unit 1, which is referring to this idea from the Shepherd, Hughes, and Locke article of the three bodies. So just to do a quick recap of that, and then we'll sort of leap off from where Shepherd, Hughes, and Locke ended, and we'll talk a little bit more about one of those, which is the individual body. So as you may recall, what Shepherd, Hughes, and Locke described were three ways of thinking about the body. And to help us understand that, they suggest that the body is both a physical and a symbolic artifact. That is, it's both natural and cultural. And they go on to describe these three bodies, which are the individual body, the social body, and the body politic, right? So the individual body is that body self, the individual form that each of us lives in and that many of us think of as being sort of the site of who we are, right? We're going to talk a little bit more about that in a second. And then the social body is a framework that recognizes that the body and social relationships are intertwined, right? So one example of that is something like thinking about or even using the phrase a healthy society, right? We're thinking about society as a sort of body, right? Making a parallel or an analogy between an individual body and a social body. That's the concept of the social body. And then the third body is the body politic. And for this, they're talking about the ways that people's bodies and political control intersect, right? So an example of that is the ways that people's bodies are essentially policed, either by themselves or by others, particularly based on elements of their identity. So for example, gender, right? We know that people are expected to maintain and present their bodies in certain ways to fulfill gendered expectations. Okay, so that's an example of what they mean when they talk about the body politic. All right, so this is, again, just recapping what Shepherd, Hughes, and Locke talked about. Right now, for this lecture, we're going to zoom in on the individual body. And we're going to talk more about how medical anthropologists have both theorized the individual body and some of the ethnographic examples that you read about that elaborate on the individual body as a site of health, illness, and healing. Okay, so the individual body, even as Shepherd, Hughes, and Locke talk about it, is something that is actually incredibly culturally variable. What I mean by that is that in different places in the world and at different moments in time, how people conceptualize what the body is as a site of existence or a site of experience, and how the body as our physical form relates to who we are as conscious people, that has lots of different forms. It takes different forms. And I know this may sound sort of hard to wrap your brain around right now. And that is because there are, for many of you listening to this, some deep-seated Western cultural assumptions about what it means to be a person and what it means to be embodied, okay? So, in other words, I'm asking you to sort of step outside of your own cultural assumptions to recognize that the way you take for granted who you are and what role your body plays in your existence, that's just one cultural framework, and there are others out there, okay? And we're going to look at some of those others now. So when we think about that sort of cultural assumption, we go directly the discussion often goes directly to René Descartes, and the idea of mind-body dualism, again, which is a fundamental aspect of Western cultural assumptions about personhood, which is the idea that you have a mind and a body, and that the body is essentially the shell that your self inhabits, but that those are distinct things, right? It is your thinking self, your mind, that is who you are, okay? That is a cultural assumption. Not all places think about that in that way. So, we can start to get a little comparative then, right? We're thinking as anthropologists here, so we want to think cross-culturally, right? So if Cartesian mind-body dualism, what I was just talking about, that the mind and body are sort of separate, complementary elements of what it means to be a person, right? And that the mind is really where your self lies. Let's look at some of the others, right? So we could look at, for example, the Chinese concept of yin-yang, which is about complementarity, right? Which is a different way of sort of thinking about personhood, one that does not necessarily privilege mind over body. Or we could look at something like this example on the bottom. This is an example that I'm taking from the work of a medical anthropologist. Her name is Marina Roseman. And she conducted field research in Malaysia with a group of people called the Temyar. And what she learned through that work, and the image on the left there that says Healing Sounds, that's the cover of her book. Okay, so if you're really interested, you could always dig up that book, which is fascinating. So what Dr. Roseman found, working with the Temyar people in Malaysia, is that they had yet another concept of what it means to be a person, and the relationship between personhood and your body and your spirit, as the case turns out to be. What she learned is that for the Temyar, a person is understood as being permeable. That is, it's not one coherent whole. Instead, it's composed of multiple detachable selves. And the Temyar described that in terms of the multiple kinds of spirits that live within a person. There's a head spirit, there's a heart spirit, there's an odor spirit, there's a shadow spirit. And what Roseman describes in this book is how many illnesses are understood by the Temyar to be the result of something that happens with one of these spirits. That these spirits, in fact, are prone to wandering away or being distracted or attracted by things they encounter in the forest. So your head spirit or your heart spirit might travel away from your body, and that can lead to an illness. And part of the healing process is calling those spirits back in, okay? So again, this probably sounds unusual, but my point here is there is another sort of culturally specific model for what it means to be a person, how a body and a self interact, and it's one that has its own internal logic, but it's a logic that's very different than the ones that that exist in other cultural settings, including for many of us living here in the U.S. Okay, so given that as sort of some basic sort of theoretical groundwork, right, for thinking about this subject, what I want to turn to now is talking a little bit about the specific articles that you read, which I think give you some good examples of both particular cases of the body in both illness and health and healing, and also give you some more theoretical tools for medical anthropology to work with, okay? So let's start with the article by Good. It's called The Body in Pain. And this is very much a case study, right? So medical anthropologists often spend a lot of time working in a particular community and getting to know lots of different people and sort of putting together something like a composite cultural model of how people in a particular place think about or act on certain things, right? This particular article, Good, really zeroes in on this one individual and his particular story and his narrative, because he's trying to illustrate certain things about the cultural context in which this case study, this person, Brian, lives and in which he's embedded, okay? So again, this is just one variation on how anthropologists work. So what Good is trying to do here, he says, through his engagement with this individual, is to access what he calls Brian's world of pain and understand how people experience pain and how they talk about pain and what that can tell us about both individual and cultural understandings of pain and what it is, okay? there are three key themes that I want to pull out from the article, and these are language, experience, and representation. So let's talk about each of these in turn, because I think, again, they have something to tell us both about trying to understand this case, and I think these are some tools that will serve us throughout the whole semester, okay? So we're building our theoretical toolkit so that we can start to apply some of the things we learned in one reading or in one unit to other readings and other units in the course. Okay, in terms of the theme of language in this article, this is a subject that a lot of medical anthropologists have been interested in and have written about, which is the idea of illness narratives, the stories that people tell about their experiences with illness. And in this case, Brian's narrative about his experiences with pain, even pain that for much of his life was undiagnosed, right? He was experiencing it, but he didn't really have a sort of illness category or a diagnosis from a doctor with which to understand what it was or where it was coming from. In terms of theorizing on pain, there's quite a bunch of interesting thinking about it. I'm going to reference a couple of different theorists. The first is Elaine Scarry, who's not an anthropologist. She's in the humanities, but she's somebody who's written a lot about pain, and a lot of medical anthropologists have worked using her ideas. One of the things that Scarry writes about is the effect that pain has on the sort of social reality of the person who experiences it. One of the things she says is that pain, quote, unmakes the world. What she means by that is it has the effect of sort of dismantling people's, their realities, right? One of the ways it does that is through destroying possibilities for expression. When there is extreme pain, it becomes difficult to, it can become physically difficult to talk, but it's also difficult to communicate with other people. It's difficult to put into words what you are feeling. Scarry suggests that pain resists language, right? It resists being sort of put into a box or put into a category that you can describe. And therefore, she suggests, healing, right, getting past illness or finding a way to understand your illness becomes very important, not only for relieving the suffering of the person, but for, as she says, remaking the world, okay? So in other words, pain and illness are not just about the physical experience in the body, they're about the whole world of that person. And pain can destroy it, and healing can reconstitute it or remake it. A little bit later in the lecture, I'm going to suggest that, Scarry's position that pain makes it difficult or impossible to communicate, that's one perspective. And there are other anthropologists or other theorists who have argued differently. Because, on the other hand, we have plenty of examples of people who are suffering with illness or with pain who are incredibly eloquent, right? Who are able to give us that insider perspective. So again, there's no easy answer to these big questions. But again, one line of theorizing is that pain and illness challenge language. They make communication, they make narration difficult. So that's one key theme, I think, in this particular piece that you just read. The second theme that I want to pull out is that of experience. And when we think about illness or pain and experience, we have a theoretical tool that we can use to try to understand this that comes from the field of philosophy. So you may be noticing already that cultural anthropologists create a lot of theory of their own, but are also voracious in pulling on the theories and other kinds of tools from other fields. So there tends to be a sort of multidisciplinary approach to trying to understand what's going on. So the philosophical theory that is often used by anthropologists, particularly medical anthropologists, is called phenomenology. And this is a perspective or approach that emphasizes the lived, experienced world. That is the nature of the world as you experience it through your own body, okay? So not starting from the idea that there's an objective world out there and that we just perceive what is out there, but starting from your body and what your body perceives, how your body understands the world around you, and using that as the framework, right? So starting with the body, not the outside world. And one of the anthropologists that has used this approach of phenomenology a lot in medical anthropology is a guy named Thomas Chortis. And he has said that the body is, as he says, the existential ground of culture and self. So again, starting with the body as the site of experience and moving from there to understand the world around the person living through that body. This is, again, a theoretical approach. And then the final theme that I want to pull out for this article is representation. One of the things that Good notes is that being able to name the source of suffering or the category of illness can be a very important step toward healing. So in the case of someone like Brian, that naming takes the form of a diagnosis, right? So the fact that Brian did not have a diagnosis, did not have a medical category for his condition for a long time, was understood or was experienced as a real challenge for him, right? So the idea here is when you have a name for it, then you can address it, then you can do something about it, right? So it's the not knowing, it's the ambiguity, it's the namelessness that is part of the problem and part of the impediment to moving forward. Now, I will say that that process of naming or identifying a cause of illness is not only include something like a diagnosis by a biomedically trained physician. It can also include something like identifying the name of the spirit who is afflicting you, that is causing your illness, right? And thinking back to the example I gave you previously of Marina Roseman's work in Malaysia, right? It could be identifying which of your spirits has traveled off into the forest and needs to be called back, right? So it's a process of naming, but not only naming in biomedical terms, okay? One of the things this sort of naming does also is to give a sense of agency to the person, right, who's again identifying what's going on, and also can help that person to understand the relationship between body and self, right? In Brian's case, he, in his narration of his experience, often talked about his body almost as if, or frankly, his pain, almost as if it had an agency of its own, right? If you'll recall, at one point he describes his pain as being like a monster tearing through him, right? So this naming also then presents the sort of different players, if you will, in an illness experience, and allows the person to navigate with or between or among those different players over time. In all of this, these questions of representation and of language, I think one of the things that we're seeing is the challenges of translating bodily experience into language or into communication. And this is a problem or a challenge not just for anthropologists or for lay people, in medicine as well, for medical practitioners to try to understand what's going on in the body of one of their patients is often quite difficult. You may have seen some of the tools like those that I've got represented here on the screen, which are commonly used tools for trying to help patients describe what they are feeling in a way that can help a healthcare provider to be more effective and more specific in how they treat, or how they either diagnose and or treat what that person is going through, right? So on the left, a pain assessment tool, and you may have been shown one of these or asked this by a doctor yourself, right? Like on a scale of 1 to 10, where is the pain? Or on the right, this is a sort of survey that's often used with patients to try to get as specific as possible about kinds of pain, variations of pain. So it's kind of interesting to imagine all those different little sensations that we put under this umbrella of pain, but then that may actually mean different things. And even just coming up with a language to communicate those subtleties is a process, right? And it's something that the people who put together this survey had to really work at. What's the difference between flickering or quivering or pulsing pain, right? But you can start to imagine those different feelings and how important it would be to make those distinctions to be really clear. Okay, so the next article that you read is the one by Livingston, and it comes from the book that I've put here. The cover is on the right side of the screen, where she did research on cancer in a hospital as being treated in a hospital setting in Kenya, in East Africa. So, looking at what is recognized as a biomedical disease category, right, cancer, but thinking of it in a cultural framework, right? So not only how the patients experience it, but also how Kenyan doctors and nurses treat it and the cultural specificity of that. And a lot of what she writes about here is how both the patients and the doctors and nurses respond to the extreme pain that these patients are often experiencing. And why, she's sort of trying to answer the question, why there's often very little use of pain medications, that people experience excruciating pain. And the focus is often not on relieving that pain through, for example, medication. The part of it's coming from the physicians who are not of a sort of training to give a lot of pain medications. Part of it is also coming from the patients, who tend to be quite stoic, even in the face of this tremendous pain that they're experiencing. So, the question that Livingston is trying to answer here is, why is pain marginalized here, right? Why is it not central in the way that it is in other cultural contexts? And part of it is the particular setting, right, in a fairly impoverished setting where there is a lack of resources, right? So things like the kinds of medications or other kinds of things that might be done to alleviate pain, there's less access to those. And that there's also a medical culture that does not privilege pain relief, right? So part of it is a sort of medical culture and medical resources in that setting. But part of it also is a sort of cultural expectation. That what she learns is that not crying out, not asking for assistance, right, or expressing pain, maintaining stoicism is culturally privileged, right? It's a cultural expectation that people often strive to meet. So it's about maintaining composure in front of other people, and that in fact, the describing or announcing that someone is in pain is understood, culturally speaking, to not be the job of the sufferer, but the job of the people around the sufferer. The people who say, this one's really in pain, are meant to be the nurses or that person's relatives, right? And again, these are culturally specific expectations around who does what in this kind of a moment. One of the other really interesting things she found is even in these really kind of harrowing moments of people on a cancer ward in extreme pain, that there is a role for laughter and there's a role for social connection. That part of what that laughter and that announcing of other people's pain is about is turning these painful experiences from experiences of isolation to experiences of socialization. Right? So again, these are fairly subtle distinctions she's making, but what she's saying is that there's something culturally specific about even something that we would think of as being acultural, like biomedical treatment for cancer. There's something culturally specific about how people go about that. So this brings me back to that sort of debate I alluded to earlier, right? That there's different kinds of ways of theorizing how pain operates in social contexts. So earlier I mentioned Elaine Scarry and her notion that pain destroys language, that pain is inherently isolating, that it cuts people off from others around them. There's another anthropologist, though, named Talal Assad, who takes a position much closer to what Livingston found, which is that pain is relational, right? That the pain of other people begs a response. right? That you can't not respond when you see someone in pain. So that it becomes inherently something shared and something social. We see that on the cancer ward where Livingston did her work, right? So we have two models here. One is pain as alienating, one is pain as inherently social. And again, it's not to suggest that one of these is right and one is wrong, but that this is a complex issue, and there's different ways that different researchers and different theorists have presented for us to try to understand it. Okay, so moving on to the next thing you read, the Stokowski article, which is about people thinking about their own health and illness in a context of high degrees of pollution, in fact, of radioactive contamination. And the very interesting thing that she found, which is that people in this setting claimed to be, quote unquote, mutants. That is, instead of trying to flee or trying to diminish the effects of radioactivity on themselves, on their health, they sort of embraced it as an element of identity. So she's trying to understand this, right? Particularly health in a context of something like environmental catastrophe, and how people respond to that, and how they think about themselves and their bodies in the aftermath of something like this. And what she found is that people had sort of very specific ways of understanding who they were and what their health status was, and that they understood themselves to be sort of, in some ways, special in their ability to adapt to a toxic environment. And that this became part of what she refers to as a new sort of biosocial identity. That is, understanding that who you are is not just yourself, right? Who you consider yourself to be, and your physical body, right? But it's also the environment, and the ways that the environment around you has, again, literally become part of the tissues of your body, right? So in this case, the people that she's writing about are rejecting the notion that they are victims, and instead embracing their quote-unquote mutant status as a sign of their strength and their adaptation to the toxic environment they happen to live in. And I'm going to end here with just a quick preview on the film that you are going to watch if you have not already watched it, right? Which is a really amazing documentary called Unrest. So please watch it if you haven't already. I think you'll find it really interesting because it's a sort of video diary almost. The woman who made the film is talking about her own experience with chronic fatigue syndrome, which is a condition that often is difficult to diagnose. Many of the people who suffer from it, it takes a long time for them to actually get some kind of answer or some kind of treatment from medical professionals. And this is the sort of journey that she tells of sort of not being believed or not being given the kind of care that people would for more conventional kinds of illnesses. And as she talks about this journey, she also hits on a lot of key themes that we've started talking about in the course and that we will continue to talk about. Those including medicalization, subjectivity, and the naming of illness and the importance of naming. So very much like the good article that we were talking about earlier in this unit, where for Brian, having a diagnosis, having a name for his illness was so important for both his sort of state of mind and for getting some kind of useful treatment. Something quite similar is the experience of the woman who made this film, right? That this collection of symptoms and experiences she has takes quite a while to sort of coalesce into the category of chronic fatigue syndrome. And even then, it's a condition where the people who suffer with it often are disbelieved, right? Or told it's all in your head. So there's that she also has to weather, is that sort of difficult emotional experience of having people not hear her or not believe her when she talks about what's going on in her own body. So I think this is another excellent case study for thinking about, again, the body in health and in illness. So that is where we'll end our discussion of body and self, and we will talk again soon.